Hi, my name is Jason Spangler, the CEO of the Innovation and Value Initiative. During the 5th annual IVI Method Summit, we explored patient-centered health technology assessment, or HTA, and charted its future course through discussions, methodologies, and networking with thought leaders. We aim to offer actionable steps for stakeholders to implement patient-centered HTA effectively. The 5th annual IVI Method Summit opening keynote discussion, titled The Patient and the Modeler as Friends, Not Foes. Our esteemed experts will discuss the intricate intersection of patient journey mapping and health technology assessment, or HTA, methodologies. This engaging session will underscore the significance of patient insights and collaborative approaches in shaping contemporary health research. It will feature, as moderator, Elisa Halpern-Paul from Venable, with the two speakers being Christine Monkhouse from Patient Orator and Melanie Whittington from Tufts Medical Center.
So before we get into the meat and potatoes of this morning's discussion, I think it would be really terrific for the audience here in the room and on the Zoom, just to get a little bit of context to who each of you is, what your day job is, if you will, and what really brings you to the conversation today around patient-centered health technology assessment. So Christine, we'll start with you.
Yeah, thank you for having me. I am so excited to be here and be a new board member too. So my name is Christine Monkhouse. I'm the founder and CEO of Patient Orator. And Patient Orator is really looking to help empower individuals to be better communicators about their health stories so that their social and medical needs can be met. What brings me to this table today, I think, is just the excitement for health technology and making sure that the voices of patients are centered in that discussion.
That's wonderful. Thank you. Mel.
Hi, everyone. Thanks for being here. Thanks for allowing me to be here. I've been trying to get on this invite list for, I think, 5 years now. So I'm glad to be here. I'm Mel.
Glad to have you.
I'm currently a senior fellow at CBER and at Tufts Medical Center, and I'm a member of ICER's Health Economics Council. So I do 2 to 3 of their economic models per year. And then I have a small consultancy where I advise and educate on health technology assessment. And kind of a bit about my background. In 2015, I started working with ICER, building some of their economic models. And then in 2020, I joined their staff full-time as the director of health economics. And the reason for that is there's a lot that changed in health technology assessment and economic evaluation from 2015 to 2020. We see the second panel come out with an emphasis on the societal perspective and the impact inventory and thinking about domains besides just costs and patient health outcomes and healthcare costs, but bringing in patient productivity, caregiver, all of these other more patient-centered elements. And then in 2018, we see the S4 value flower come out that again has all of these petals that are more societal level focused and are thinking about things besides healthcare costs and patient health outcomes. And so I wanted to try to find a way to incorporate that into health technology assessment. And there needed to be methods developed to do so. I think as a field, we've really emphasized a lot of talk around these things, and we need to think about now, how do we make actionable steps that can be practically and pragmatically implemented into HTA? And so that's what I hope to do. I left ICER last year to start kind of what I'm doing now, and I'd say a day in the life of my job. I'd say a third is spent doing CBER work, where I'm hoping to test novel methods for advancement of HTA. A third is working on ICER assessments, building those economic models, and then a third is kind of advising and educating on value assessment.
Wonderful. I love what you said about we've talked a lot about it. Now we have to start really doing it. And that's really what today is about. That's our call to action. So we're going to keep coming back to that True North. Christine, would you tell us a little bit about how and why you created your organization?
Yeah, that's a lot, but I'll try to do it very quickly. I created my organization because I worked at the bedside as a nursing assistant while in college, and I had the this amazing opportunity to speak to thousands of patients in the New York City area during that time. And I just loved their stories. They were at their most vulnerable, but here were rich stories with context that were not being captured by the hospital, that is not necessarily related to health, but it is, or it drives the impact of health. And those were social factors. So when I saw a patient come back in, I would say, oh, you're here again. And the response would usually be, it's because I have no one at home. And when I fell, I was there for a very long time by myself. So after those series of stories and just being in love with just that human factor of what happens when people are at their most vulnerable and what it is that they need, after that role, I went on to being a care coordinator, and I saw a different side of that, which was the social impact of what was happening. So these were individuals that I was working with that were they were very vulnerable individuals that had high social needs, and then interacting with the health system from that end was that the social needs were not being addressed. And so I really wanted to make a way that would bring awareness to the humanism in those stories that I've been hearing and the themes that I've been hearing over the years, and started traveling the country and capturing those stories. There's a documentary called Humanizing Healthcare, which I created. And after capturing those stories and in my own health journey, realizing that capturing the stories alone would not be enough, but helping to empower individuals to be good orators, so to speak, would be the next step of what we would do. So
That's wonderful. So capturing the stories, helping people tell their stories. And then I think what we want to talk about is taking that very important kind of qualitative data, if you will, and how can that help empower the quantitative work, Mel, that you and your colleagues are doing, so that we have all the petals of the flower, if you will, addressed, and telling that story in a meaningful way in that patient-centered health technology assessment. Great. So people, as we just said, are talking a lot about this. We have a definition, as Jason said, and one of the other things I want to lift up is, if on your worksheet, there's the definition. If you have edits or suggestions at how you would change the definition on your worksheet, feel free to make annotations. And again, we're going to collect everything back, and then we'll crowdsource it all and see where we land. So we're talking a lot about patient-centered health technology assessment with respect to value frameworks. We could spend all day talking about this. So I'm going to limit you to up to 3, up to 3 methods or practices that you think patient-centered health technology assessment needs to entail. Do you want to go first, Mel, as our quantitative person, and then we'll go to Christine for the patient narration side of the story.
Yeah, thank you. I'd say number 1 is stakeholder engagement. That's certainly a method, and it's stakeholder engagement throughout the entire process. When I work on a value assessment from the very first scoping phase, that is a major area to influence the value assessment. That's thinking about what is your population, what's your comparator, what outcomes are important. Also related to that I'm starting to think out at that phase is, what is the model structure? And what are the clinical outcomes and patient important outcomes? So I'd say stakeholder engagement, absolutely essential. I think that can inform things even beyond just qualitative information. That can inform what the whole assessment is going to look like and how you're going to build your model and what inputs you're going to include. So stakeholder engagement, 1. I'd say number 2, I think you could call this a method, would be encouraging the societal perspective, and whether or not that becomes a base case. That's a common word we throw around, but still encouraging a societal perspective, providing inputs to be able to be incorporated in that. I think the societal perspective gets a little bit more patient, the more traditional healthcare sector perspective. And the third is a method that I have a newfound interest in, aggregate DCEA. I'm sure we'll talk about.
Would you unpack that for a layperson like me who doesn't know all the acronyms?
Well, yes, and I'm still learning too. So DCEA is distributional cost effectiveness analysis. I know we have an equity session coming up here. And I think if you know anything about DCEA, it's probably, oh my gosh, it requires so much data to be able to do a DCEA. So a DCEA is kind of an add-on to cost effectiveness analysis. Cost effectiveness analysis largely focused on efficiency, how much can we get for the money. The distributional part then now starts bringing in equity. And now it's thinking about like, well, who is benefiting and who is losing? DCEA, a lot of data. Aggregate DCEA, a lot less data, but still being able to get at some distributional effects. And so I think aggregate DCEA is a third method that I would like to pitch as a kind of a baby step to be able to get at some more quantitative equity methods.
Great. So with respect to the stakeholder engagement, I love that that was your number one. And I don't know if that was intentional or not, but what I heard
Say it was.
perfect. What I also heard you say is from the get-go, not we've put something together and now we're involving stakeholders to react to what we put together. But what you're saying is before you even really start, you know, at mile marker 0, it's stakeholder engagement. And then throughout the whole process as you're developing the methods and the analysis. Is that?
That's right. And I would really say the upfront part is where I find it most beneficial. I think at the end of assessment, a lot of times people want me to say like, Mel, which input came from a patient group to inform your model? And it's like, yeah, that happens. I mean, that certainly happens where I've used inputs for a patient group, but that's not really how the model is influenced. I want us to stop thinking about a specific input and more think about structurally where the health states aligned with what patients found of influence, were model parameters that were included informed by, hey, we heard from patients and their stories that productivity time is an issue. Caregiver requirements are substantial. And then we look for, is there a meaningful impact of the treatment on those things? And so I think it's more in the structure where I find where economic evaluation can be very patient-centered. I should also say, I'm speaking on the modeling, given my expertise in the title of this. HTA as like an entire entity is much, much, much more than the economic model. And so there are a variety of ways for HTA to be patient-centered, but I'll just be approaching this from a modeler perspective.
Okay, great. Christine, hop in here.
So I don't have a scientific background, so this is very
fine.
interesting.
Yes.
But I think that if you're going to study anything, if there's patients receiving the services for that thing, right, they need to be involved from the very beginning. And for me, that means that they're involved in even the co-development of that study, and their care partners as well, because there's immense data in that. I think the second piece is when you're looking at collecting information from patients or studying them in some way, to consider the whole person. So what are the societal factors? What are the social determinants of health or social pieces that are impacting or driving their health? And I think that the last piece is to consider a mixed method approach. So I love stories, but I also recognize and acknowledge that the data numbers are important. So combining those two, I think could drive a very impactful study or whatever it is you're studying.
That's great. So what I heard from you is patients agree with Mel from the very beginning need to be involved, but not just patients, caregivers, other in their ecosystem, if you will, and hearing from them a 360-degree view of their lived experience. So not just the treatment or the interaction with a healthcare provider or the healthcare system, but really what's going on entirely in their lived experience as they are on that journey, their patient journey, and what are the social determinants, what are the other factors, and how do we capture that and then factor that in. And I think that's a little bit about all the petals on the value flower, if you will. And Christine, what I also heard you say is that it is this balance of qualitative and quantitative. So I love that we already have agreement. This is terrific. Okay, so I'm curious, Christine, you mentioned that you travel around the country, you did this documentary, you talked to a lot of different people across this great nation. In your travels and in those conversations, what are some of the examples of costs, or maybe said another way, you know, the negative impacts? Some costs are actually financial, some are you know, social costs, some are you know, societal costs. What are some examples of costs that people lift up to you, and that you think maybe right now is not being captured by modelers like Mel? I'm not going to say Mel's not capturing them, but people maybe like Mel.
I think the indirect cost, the opportunity cost, I'm curious to see if it's being captured and how it is being captured.
Okay.
I've heard stories from people where one individual was basically afraid or hesitant to call an ambulance in being in a dire situation because they couldn't afford that fee that would come with the cost of the ambulance, right? Who couldn't afford, in addition to that, just the MetroCard price to go to his regular appointments. Heard another story or interviewed someone that shared the story of being in medical debt after having life-saving procedure and now being afraid not so much of the conditions they live with, but having to interact with the healthcare system because of that fear and financial anxiety that comes with what kind of costs might incur, right? Another story, just recently I was at a community health, community pharmacy, and the person next to me was there to uplift their medication almost a month late. The pharmacist said to that individual, why are you late? And he said, my insurance, like I changed my insurance. And she said, well, you have a $4 copay. And he said, well, I never had a copay before with my other insurance. I can't afford this. And she said, I can't give you this drug for your diabetes without that $4 copay. So those are some of the factors I think that are not being considered. And in my own health journey, I live with a condition called uterine fibroids, and it took me 3 years to get that diagnosis. That's 3 years of pain and suffering. I don't know how that's being captured right now. And then what happens after that diagnosis and what are the costs to, let's say, the insurer or even myself. So those are some of the cost examples that I would share.
Those are great. Now, as you listen to what Christine shared, what comes to mind for you from where you sit in this ecosystem?
Yeah, I mean, the one thing that I always go back to is in a health technology assessment, it is still an assessment of a specific health technology. It's not necessarily an assessment of the comprehensive burden of a condition. And so that's kind of what I want to leave as a kind of a, make sure I communicate is there are, now that's not to say that patient stories aren't essential to understanding how that technology should be assessed. But there are some things outside of how a treatment could meaningfully impact a condition that could be seen as like outside of scope for the health technology assessment. And so a lot of those things I would say are not captured. And I think in some situations if the treatment could have a meaningful impact on them, then HTA should find a way to incorporate that into the economic modeling if the treatment could have an impact on them. And so that's something that are always tough conversations as part of an assessment of fully understanding how severe a condition is and all of these kind of domino effect consequences that can come with it and the indirect costs. But then there's that second step of does the treatment meaningfully impact that? And so that's what I consider as my job is I take in all of this information from patients and patient groups. Then I understand, okay, these are the things that I need to look into. I need to look into costs. I need to look into patient productivity. I need to look into caregiver. And then it's the next step of, well, does the treatment meaningfully impact those? And so just to keep that second step in mind. But then, I think this is why patient story is so essential. One reason why I was drawn to working with ICER is because of the public deliberation process, that public meeting. I remember my first ICER assessment I worked on. It was exhausting. It was so much work and such quick, rapid deadlines. It was stressful. My heart was racing and I'm never doing this again. And then I got to the public meeting and I was just like, wow, that was great. We had the manufacturer in the room, the payers, the patients, the clinicians, and it was just this open dialogue. And I think that's where patient story is essential at a public meeting to round out the story, but then to always keep in mind that the assessment is still of a particular health technology, not necessarily the overall burden of a condition.
So in terms of your work and when you're drawing the lines, if you will, and focusing on does this technology, does this intervention, this treatment have a direct and material impact, right, on the condition? And you listen to Christine and what she shared. Is there any way to bridge the gap to say, okay, transportation costs are significant, right? Is there in your work, are you able to take some of these social burdens that are maybe a dotted line to the disease, maybe not a straight, direct, yellow highlighted line, and incorporate those? And if so, can you give some examples?
Yeah, no, that's a great example of one that, okay, we hear from patients that they're having to drive or having transportation challenges. So that should be a flag in the modeler's head of like, look at the transportation and then think, well, how does this treatment change transportation? Are you having more visits to the healthcare system? Are you having less visits? And so I think that line is pretty easy to draw. And so I think that is a way how we can get to be more patient-centered. And I think that's why it's sometimes challenging at the end of a value assessment to point to, hey, what input came from a patient? It's more not a specific value, all that certainly does happen, but it's more so, well, what things do you include in your assessment? But there is always that second step of, if the treatment doesn't have a doesn't have a differential impact on it, then the comparator, right? We are always comparing to something. And so if the transportation challenges are the same, then they need not go in the evaluation. If they are different, that's when it should.
Okay. So you lifted up this experience that you shared about ICER, and then, being wrecked by the prep and the process, and then going to the public meeting and being buoyed by being in the room with all the stakeholders. Is there something after you had that experience that either changed specifically what you were working on, or just changed your orientation going forward in terms of how you approach modeling?
Oh yeah, and there's just been so many. I mean, I've been working on their assessments now for 9 years, and so I'd say every single assessment has evolved substantially from feedback from stakeholders. I do think as time has gone by, that again, there's more of an emphasis on the societal perspective and these novel value elements. And I think patient story is essential. And I think one challenge with health technology assessment, this is where the spice comes out, is it's still a population level tool. And so the direct outcome of a health technology assessment, it isn't necessarily intended for the patient, right? It's thinking about plan members and how can we use these pool of resources most efficiently. Now, I think it still can be patient-centered, because I think that's how it can be accurate. Like, I think accuracy comes with patients involved in health technology assessment, because your model structure is appropriate. You're, incorporating things that are actually characteristic of the condition and the lived experience. But there's still the outcome of a health technology assessment might not be in the direct benefit of that specific patient population, because we're thinking about plan member resources. And so sometimes I feel bad requiring so much of patients in participation in health technology assessment, because they aren't the only stakeholder that is kind of the intended stakeholder of the outcome. So there's that disconnect.
Fair enough. So I saw Christine kind of nodding at one point, and I don't want to say you rolled your eyes, you raised your eyes. I just want to be accurate. Raised, eyebrows went up. It wasn't like my teenage boys, like with the big, mom, you're making me crazy eye roll. Hop in here. So as you listen to Mel, and she shares kind of from where she sits, and not quite the secret sauce, but I would say, a peek behind the curtain here. And you have all the stories of all the patients, and your own lived experience. What's your reaction to what she is sharing?
A lot. I'm learning a lot, actually. I think that the first piece is around the issue of access. And something you said about the patients not really being impacted by whatever study is being done. I think that they are, like you said, and probably that's when I collected my face, right? Like you said, that this is at a population level, if I'm quoting you correctly, right? So, I'm just thinking about people and how they access any said service, and how that impacts them, and how research can really help mold and improve access in a way.
Right. No.
Yeah, no, I think it's when I'm talking population level, I don't necessarily mean a if we're doing an assessment asthma, I'm not talking about the asthma population. I'm talking about like the US population. And we have this, pool of money and we want to get the most bang for our buck. And so I think that's the challenging part for an assessment is it is specific to a patient population, but then the outcomes are wider than that. And I've certainly felt that in my patient and caregiver journey that I'll be like wearing a patient hat for certain conditions that myself and my family are impacted with. And then I kind of have to put on the HTA practitioner hat. And they're just different missions. And both missions are very important and essential for the ecosystem. And I think there is a little bit of overlap and collaboration and working together is essential. But I still think an understanding that the underlying mission between, say, a patient group and a health technology assessment group is different.
So as we're having this conversation, several things are coming to my mind. So one is, Mel, what you shared, which is there's some things that they're incredibly important to the patient lived experience, but they're just not appropriate for the model, for the math, or hard to capture.
I would say it depends.
Okay.
That does the treatment meaningfully impact it, I think, is whether it should be included.
So with that, I'm going to put on my mom hat for a minute and say, and this is the caregiver, right? So Christine lifted up, it's not just about the patient's lived experience, it's about the caregiver. So let's talk about caregiver anxiety for a minute. I mean, not that I know anything about this, mom of teenage boys who are learning to drive, no anxiety in our house whatsoever, okay? So anxiety is real, right? And when you have a chronic condition, it is probably something that the person living with the condition, and then depending, like let's use asthma, right? Moms with kids with asthma or peanut allergy, fill in the blank, right? Lots of stress and anxiety for the whole family ecosystem. A treatment that reduces, let's say, asthma attacks or reduces the risk of an anaphylactic episode with peanuts, right? Could not just benefit the person with the condition, but really make a material quality of life difference for the family. How would you factor that in?
Yeah, so I am a mom of a 7-year-old with asthma.
I didn't know that,
very
just for the record.
Asthma exacerbations. Finding a treatment that she responds to has been an issue. I'm grateful that there are so many treatments in the asthma space. Those things can very easily be quantified in an economic model. You can incorporate caregiver quality of life. You can incorporate caregiver time missed from work. You can incorporate additional caregiver healthcare costs due to anxiety and depression. Those methods are there. I've done all of those. And then the question is, does the treatment meaningfully impact that? So we have methods to do that. Good news.
So Christine, as you hear that and using this example, and again, as you travel the country and you talk to patients and caregivers, do you feel or think that the assessments that are being done really do capture these other petals on the flower, if you will? Or does it feel or seem like it's not being captured?
It seems like it's not being captured, which is why I'm fascinated with your perspectives that you're sharing. It seemed very silo, like the researcher world seems very separate from the patient world. Yet the work that researchers do is so very impactful for the patient. So I love that question that you asked, because so very often it's not just the individual patient that's impacted by the researcher, right? It's the family dynamic, it's a population of people, it's the society as a whole. Because if you can solve for any illness, then you can make a group of people healthier and they can contribute economically, right, to that country, that society.
Right.
So it's I think what needs to happen is somehow bringing together of stories of individuals and groups of people and bringing those researchers together when appropriate.
That's great. And Mal, what I hear from you is, yeah, we have ways to do that and we're doing it. So maybe it's communicating it.
Yeah, I think
to patients and, outside of the world of modelers, right?
Yeah, I think communication and we're doing it if there's evidence available to do it. So I think there's also that and, right? So I have incorporated those caregiver things for Alzheimer's because there was substantial evidence available for caregiver quality of life, for caregiver healthcare costs, and they were attached to something that could be changed in a model. So they were assigned to certain health states. Well, great, the treatments that I'm modeling have more time in these health states, so now we have a differential impact. Let's keep going with the asthma example. I don't know if there's robust evidence on caregiver quality of life by how does that worsen during an asthma exacerbation. So I don't want to give modelers too much credit. It's not like this is universally being done in every single model. It is dependent on, one, do we hear from patients that this is an important input to be incorporated? Two, could there be a differential impact on the treatment? Three, is there evidence to actually be incorporated? And I always hate that when it's like, we need evidence.
So those three questions, and I think you unpack them in the order of operations, right? So one is upfront, as we've been talking about, find out from patients the things that matter. And then does it have the impact on the intervention? And then is there evidence of that? So if we get hung up on, let's say, is there, to your point, evidence? The Alzheimer's example, there is. Maybe there's not in asthma. That's a call to action then. That's something where maybe a collaboration, because this morning's about, right, we're friends, we're not foes, where we can identify the questions that should be asked and that we need answers to in order for you to have what you need to plug it into the model. And then, Christine, maybe it's the work within the patient advocacy community, maybe with some industry stakeholders and others to then fund that research to get the data that Mel and her colleagues need. Does that sound like a fair next step potentially here?
That's perfect.
Okay, great.
No, I think that's great. And it would require collaboration. And one thing that I would just ask is there are amazing studies and research that's coming out of patient groups. And there have been times, and this is probably my worst experience working with us on assessments, is when there's been great research done by a patient group on, say, caregiver time spent caregiving. And it's like, yes, this is exactly the domain I asked you for in the data submission. But it's not, it's for the condition as a whole. So let's keep going with asthma. How much time do you spend caregiving for asthma a week? Well, these treatments that we're evaluating aren't curing you of asthma. You still have asthma. And so using that data point, I spend 3 hours per week providing care for my child with asthma. Well, these treatments aren't shortening your time with asthma, right? So if we could ask one extra question of how does your time caregiving differ when your child's experiencing an exacerbation versus not experiencing an exacerbation? And then, hey, this treatment is in fact impacting exacerbations, and it can have these downstream impacts then on caregiver time. And so there's that one extra question. And so I always tell patient groups, when you guys are designing your own work, just shoot me a quick email or call me and I will quickly tell you, oh, this is probably what the health state structure would look like. Maybe add one more question to be able to differentiate.
So what I hear, Mel, is that the patient advocacy side has to do what we were just saying that the modeler side has to do, which is involve the researchers and the modelers at the get-go too. So it's not just on you all to involve the patients, right? What I'm hearing is if patient groups are designing a study, they should pull in a modeler from the beginning to help design the questions. So then the outputs are what you need.
Yeah, I'm embarrassed to say I hadn't thought about that before. I love that.
So it's a corollary. So, okay, great. I got the sign that now I need to pause my prepared questions and turn to the audience. So if you would raise a hand and then we'll get a microphone to you. If you would identify yourself with your name and your affiliation, that's great. We'll start first in the room and then we'll see if there's any via Zoom. So if we could get a microphone here at this table, that would be great. Thank you.
Claire Sachs. I am a patient. I'm on the patient side. I have a patient advocacy blog called The Patient Advocates Chronicle and a consultancy called TPAC Consulting. So I have a couple of comments. One is I would request that you continue to look for ways to incorporate not just the social aspect, but the mental health impacts as well. And this is something that can be quantified among patients because it does affect both outcomes and adherence. So you have anxiety and depression that will rise, as well as what I like to refer to as the emotional trifecta, which is guilt, shame, and fear. And this happens in child patients as well as adult patients. So if you can keep that in mind as you're building your models, those of us who have to go through it every day would really appreciate it. And when you're talking about the caregivers, because I've done that too, there's always the refrigerator hum of anxiety. So when you're asking about that, and there's a specific incident, with a child with asthma, does that go up? On a scale of 1 to 5, how much does it increase based on, that particular incident? And then the other request that I would make is, if you can, please incorporate non-affiliated patients in your patient input. Because when you have patient groups, they're wonderful, but they're also the more empowered patients. And when you're talking about reaching more marginalized communities, you want to get people who are less empowered, who have been hit more with trust issues by the system. Because if you can get input from those populations, then everybody else will fall into the solutions bucket. Does that make sense?
No, that does. I appreciate both of those comments. Do you have for the second one, do you have recommendations on best way to reach those folks? Because I do think a lot of
Absolutely.
times patients are identified from the patient advocacy groups and
Online groups, because this is where you're going to get patients and caregivers both saying, when I brought this issue up with my provider, with my clinician, they'd never heard of it before. So has anybody in this particular online support group ever had this issue, and what did you do about it? Either what have you tried that did not succeed so I can avoid doing that, or have you had success with any of these things? And a lot of these groups are private, but if you go to the people who run it and make it clear that you're doing something in their membership's best interest, and you ask them to float the idea to their group, that you want to come in as a researcher and really do your best for this patient population, I think that you'll find people are very receptive.
Great, thank you. I think we had another at the table.
Thank you. Shelby Harrington from Avalier Health. I'm curious, Mel, specifically when you were speaking about the evidence gap, that you have the models available, but the evidence needs to be there. From a researcher or a manufacturer's perspective, is there optimal timing to when that evidence is generated? Because HTAs are not done on a continuous ongoing basis, updated. So if you miss that train in your clinical trials, when is the best point at which to catch up and generate that evidence?
Yeah, that's a great question. I don't think the responsibility should only be to the manufacturer either. I think a lot of those data evidence gaps that we have aren't necessarily they need not be treatment specific, like not necessarily have to be part of a trial, but it could be condition specific. So there can just be more research funding and more studies that are being done to say, hey, what is the caregiver impact for time missed from work to deal with an asthma exacerbation? Like, those studies could be done now. I remember when John and I were working on the mepolizumab asthma assessment in 2015, that evidence didn't exist. And we're like, oh, like some hours make sense. And now that number is cited all the time. It's like, no, you all should still collect those data. And so I don't think only the manufacturer should be responsible for providing these types of data. And I don't think it necessarily has to be part of a trial, but it's we can start building our armamentarium of evidence on societal perspective impacts. And then it can be at the ready when an HTA gets called.
Great, thank you. I think we have in the back and then in the front.
Great. Thank you. We have a question from our live stream audience. This question comes from Danny Van Leeuwen. How would you budget for patient-centered modeling so that time for that patient engagement from the very get-go all the way through the entire process of that modeling, building, and HTA process?
Yeah, I don't know. I'm budgeting time-wise or money. I guess those are kind of related. I would have to think more about that. I think it could be on a spectrum. And that's one thing that I think HTA can be an action item for HTA is to increase the number of resources and educational materials to make engagement easier. I would just say from my experience at ICER, I think there's the scoping phase where you're talking with the different patient advocacy groups, then you're doing patient interviews and caregiver interviews, and then there's multiple comment periods. So it's not a quick lift. I mean, it requires a lot of time and a lot of resources. And sorry, that's not a good answer.
I think it's an honest answer, right? And it probably also depends on the nature of the particular assessment. So, yes, thank you. Once you start talking, it kicks in.
I don't know about HTA in the infancy, but what my question is when you are thinking of what you're going to ask or the questions in the research or things like that, do you have advisory boards like, okay, I'm Dion, so I'm sorry, with Rare Black. So when I deal with researchers, usually when we are working together, there is a common goal and they're trying to get something from me and I'm trying to get something from them. And so in the infancy part of this, do you have like a lay person or a company like his? Okay. Do you have a company like Kirsten, her company, or a board that you go to ask questions to make sure that patients are in the forefront of whatever you're trying to do? Because I know you said that we don't always have the patient voice, but it's imperative that it happens. And so if you can do it in the infancy where you are saying, we're looking for this, but the patient is saying, no, this is needed too. So how can we marry both objectives to get a better outcome?
You want to
Yeah, I can go
answer
first.
and
but
then
I'd
we'll
love your
invite
perspective.
Christine.
Yeah, ICER does have a patient engagement team that are ICER personnel, and they kind of have a process for ICER engagement. And then I believe they have a patient advisory board as well. But I do think assessment, this is just my personal experience, I think assessment by assessment, engagement is early engagement with a patient group is initiated, and then the level of engagement does vary.
You have a follow-up, Dion?
Yeah, I do, because I was explaining to someone here that I'm part of a center, that each center has an advisory board, but some advisory boards are more effective in recruiting for research. And some people have advisory boards just to say that they have an advisory board. They don't listen to them. The IRB may say, you need this to get this funding or to do this thing. And so my question is how, this isn't a dig at you, it's just as a whole, how engaged or how can the patient population make sure that the advisory board is being utilized to the best of its ability to have a better outcome for the research?
Yeah, unfortunately, I'm probably not the best person for that. I'm not at ICER anymore, and so I don't have direct engagement with a patient advisory board. I can say from assessments outside of that advisory board, engaging with the patient's community is certainly standard practice.
Dion, I think it's a great question. And I think helping to ensure that those efforts are authentic, right? It's not just to check the box, right? That it really is a dynamic dialogue between the researchers and the patients who are volunteering their time and sharing their lived experience. So I think that's incredibly important. John, did you want to hop in with a comment here?
Absolutely. Hi, everybody. I'm John Campbell at NPC. Great panel and discussion so far. I wanted to add to this line of questioning in terms of maybe both of your thoughts on, we discussed that patient engagement was really important and from the start. What are your thoughts on being honest about the stakeholders' objectives and a sharing of those objectives with each other at the start? There could be concern that if we're really honest about the objectives, that certain parties may not want to participate. Because although there's overlap, I think, in objectives, there's uniqueness. And so would love your thoughts on whether that's a good way to start and any potential risks in doing so.
That's a great question, and I think that'll be, we'll count that in our spiciness here. Okay, Christine, you want to go first?
No, I think that's a part of what's missing here. I don't know what the risks are involved because I'm not a researcher, but I think that patient participation is essential in the designing of the questions. It's kind of why I said in the beginning that there has to be sort of bringing together, because right now it seems very siloed. So bringing the patient to the table, but having a very basic lay conversation about what the objectives are, what the goals are, and finding those people who want to participate, because not everybody, like you said, might find it appropriate to participate, but that very honest conversation has to happen.
Is essential. And I think, Deanna, goes to your point, because then patients could either opt in or opt out. They might say, I don't want to be window dressing, or I don't share those objectives, or I'm not in agreement with where this might be going, right? So to honor where the patient's voice can contribute, or they choose to sit out. That's great. Did you want to comment, Mel?
Yeah, the word that I like is transparency. I think both stakeholder groups, HTA and patients, need to just maybe if it's not transparency, maybe it's more just bluntness to say, yes, that is a big issue. Like, we hear you. That's an issue. I understand. But the treatment doesn't meaningfully impact that. That's why it wasn't incorporated in the model. I think like there's that closing of that loop. So I sometimes feel guilty of, requiring so much for patient groups and patients to talk to us, getting all of that information, but then it's like, well, then I go back and say, okay, look, where does the treatment impact, and can we actually incorporate, do we have evidence? And maybe the loop isn't then closed of like, actually, no, we didn't do that because the treatment didn't meaningfully differentiate there. So maybe that could be an action item of.
And that could help address, I think, what both Christine and Deanna are sharing, which is patients take their time, right? And caregivers, and kind of lay it all out, right? They tell you their lived experience and they share it. And then if it's not reflected, they may feel not heard, and they may feel like it was a waste of their time, which you can understand. You just said, right? You get how it could feel that way, but maybe using that closed loop communication to explain why it couldn't be used or why it wasn't used. And it's still important that they shared it, right, for that whole lived experience and understanding the whole 360 experience, but that for this particular assessment, we couldn't utilize it because it didn't have a direct impact, right? So not perfect, but to your point, at least an honest conversation and sharing, and then it maybe will help patients feel maybe not better about the whole process, but understand why when they share some information, it's not utilized, because you don't want to ever feel like you're wasting your time. Nobody wants to feel like they're wasting their time, right? I think we have time for one more question. If we could get a microphone to the center of the room, and then we will wrap up the conversation. Thank you. Name and affiliation, please.
Thank you. David Palacios, Involved Care Innovations, a consultancy body helping in this process as much as we can. It's fascinating to see something that everybody knows already in terms of the pieces of the puzzle. And you mentioned, Christine, that is in silo. So the call to action might be also not only to continue discussing what is the problem, but how to fix it, right? I think that everybody here is entitled to say, we can do better, we can involve researchers, we can create this mindset of involving data and creating evidence and work with the communities. Question then would be, and I want to get your thoughts on that, is what is the next step to do that? And stop just talking about the possibilities, because apparently everybody think about the possibilities, there's more openness about this and appetite to do more, but everybody's back to their own work and things continue the same, right? I've been in the industry for 20 years, and let me tell you, I was chatting with my colleague here in the table, nothing really had changed that much in terms of practice. That's why this meeting is so important. So my question to you guys is, what do you think that we can do out of this meeting today to start closing those gaps, closing those silos, and involve the people that need to be involved, practically speaking? How we create that evidence that you mentioned, Melanie, how we can capture those stories that you mentioned, Christine, into the evidence, and how the researchers really are opening to change and adopt the processes to make that possible. Otherwise, you have this creation, beautiful evidence, and then it's not matching with the process. So it's like the synchronization of the pieces seems to happen somehow. Any thoughts?
It's a great question. In fact, it's very close to what my closing question would be. So I'm going to not ask my closing question, just have the two of you close us out with a response.
That was a wonderful question. I think that an action item for the people in this room is to really invite patients to participate, make it accessible for them to participate. I love that question that you brought up, and actually that suggestion, I'll add that as an action item. Patient advisory groups, make them be effective, be transparent in the creation of them and what it is that the researchers are asking for, and having that open dialogue so that both sides could come to a common ground. And I do think there's a communication issue here, both with communicating the importance of research, but also on the other side, the importance of the stories and bringing those together.
That's great. Thank you. Mel.
Thank you. Yeah, I would say for the kind of researchers, funders of researchers, academics, continue to develop work in this space, develop evidence in this space. Let's stop just writing commentaries, talking about it. Let's actually do some applied examples. I love like this term call to action. I love that, if we can create this list of calls to action and then let's actually make it actionable. That's the next step. We actually have to apply it. So for the researchers, let's get to work. Let's do this. For HTA, I think it can amp up education and training of having some resources of, economic evaluation. Very, very few people in the world know what economic evaluation is. And, if we want patients to be able to hit the ground running with engagement, there can be kind of this body of education and resources available. And then for patients and patients communities, just please continue to engage, ask questions, and then anytime you're wearing that researcher hat and developing your own research, reach out to an economist or someone at HGA and maybe add just one extra question and make sure it can be differentiated by a potential treatment.
Great. Wonderful. We could probably talk for the next hour, but we have to go to our next panel. So please join me in thanking Christine and Mel.